So Dr. Avgeropoulos, and I may have just messed that up. I just will call you Nick. He is a medical neuro-oncologist with over 25 years of experience focusing on clinical practice and translational research. His fellowship after neurology residence include the Medical University of South Carolina in neuroimmunology, Yale New Haven Hospital neuropathology, and Massachusetts General Hospital in medical neuro-oncology, all focusing on different aspects of brain and spine tumor management. He most recently joined Novocure as their Global Therapeutic Area Lead for CNS cancer. And his talk today is actually very exciting. He is going to be talking about living with GBM and TTFields. So, Dr. A, you have the floor.
I'm grateful, and I'm grateful, of course, for the invitation. I'm always grateful to really be reminded, even after 30 years, of what this is all about, which are the questions, and finding solutions. So with that, I will share this presentation, and I'll have a I'm sorry, Deland, did you have any specific comment or question, or you were just prepared? I saw you rustling papers, so I'll go ahead.
Okay, I was just reviewing some of the other questions that came in on people's registration forms. So you please present. I'm eager to hear.
I'm on it. And I want to assure your audience and everybody joining us, I'm not in a rush through the presentation. I'm really grateful for that. And whatever it takes, because this takes precedence. So for my presentation, really, it's an introduction to those of whom are unfamiliar with Tumor Treating Fields, the device and the therapy, and also to drill down onto some of the impact that Tumor Treating Fields has had in the space of glioblastoma, and more recently, lung cancer getting an approval. So there's another indication, and that's right. And yet, even more, there was a recent press release about further treatment advances there. So with that, I'm going to focus on glioblastoma, of course, which is the purpose of this. Please feel free to call me Nick or Dr. Nick, as I was in the clinics for 25 or 30 years. And so, again, let's move on. So here is the Tumor Treating Fields, or TTFields. Some may be fully aware or users of it, but I want to start out by talking a little bit about the timeline of this. We're talking about 25 years itself in the making, starting from the laboratory analyses, and then from 2006, so almost 18 or 20 years ago, the EF11, which was used in recurrent or progressive glioblastoma, was evaluated as a proof of concept. And when compared against the best therapy at the time as a single intervention, in that study, there was no disadvantage one way or another, except to say the quality of life was better and maintained for longer. And so, with respect to the ongoing evolution of that, we see in the 2009 timeframe, the pivotal study, so-called EF14, had a randomization. So before that, there was the chemoradiation with temozolomide, and then subsequently the 6 cycles of chemotherapy, most of the time called either the STUP or European regimen. And then on top of that would be, in 2 out of 3 arms, added Tumor Treating Fields. And so in that study, and along the way that unfolded over the course of over 5 years in terms of getting its FDA approval, we noted that there was a definite improvement in the progression-free survival, a definite improvement in median overall survival, and also, quite importantly, there was a 160% improvement in 5-year survivorship. So that is, a message that certainly resonates with many. And honestly, that's the one that just keeps coming back, and in the best way. So, we keep setting new bars, and I want those bars to be way over our heads so we can jump for them and get past them. So, as we move on after the FDA, this becomes available in Japan, in Europe, in varying countries under varying capacities. And then there were the other indications, which I mentioned, which was the mesothelioma was one of them. And the other, although the LUNAR study did not yet end up in any kind of approval, we anticipate that that's going to be out very soon. We hope for patients, but yet that study met its primary endpoint, and we're very excited about it. And it was presented in a major conference last year. So Novocure in general is dedicated, particularly focusing on the most difficult and aggressive forms of cancer. That's our space. We're not, looking to make a more efficient anti-cholesterol medicine or blood pressure medicine. We're talking about, running as the as the saying is, it's like, well, when there's danger, do you run towards it or do you run away from it? Sometimes, honestly, you have to run. As they say, there's this fight or flight. Actually, from a standpoint of observation, it usually is freeze, flight, and then fight when you have to. Here, we do the opposite. So we run into it because that's where we got to go. And if not us, if not now, when and who. So, and that goes for all of us, I think, on the call. And so with respect to that, I've covered a lot of those. And again, I think that the main message here is that this is not a new therapy. This is an established, approved therapy that is a standard of care. And in fact, when you look in the NCCN guidelines, it's the only preferred Category 1 recommended treatment for glioblastoma. There are Category 1 recommendations for the STUP European protocol, but those are standard Category 1. So that is a testament, at least in the US market, that there is that preferred designation. So what is this, and where's the mystery in all of this? And so, as I was going through training, one of the key questions is, what can we use for maintenance therapy? And to give you an example of some of those, we used to prescribe high-dose tamoxifen because there was some rationale in that very high-dose tamoxifen that maybe it repressed some aspects of tumor growth. And what we ended up doing was we ended up giving people blood clots, because that really was at that high a dose, that was one of the main adverse events. And we didn't find that there was any kind of equitable trade-off in terms of benefit. Then we tried things like Accutane, which was found in a phase 2 study to help. But then when you give it at high doses, it ends up actually increasing intracranial pressure and becoming quite problematic in many patients. So here, as opposed to those therapies, here you actually marry that notion of a continuous therapy, which is the maintenance idea, but you marry it with an active treatment. So this is not some wet blanket that's kind of keeping things under wraps. This is an active antimitotic therapy that is destroying tumor cells real time. How does it do that? The device, as you can see depicted on the right of the screen, has two opposite, almost perpendicular placed arrays. Each array has 9 ceramic leads connected by flexible, circuit. And so it alternates. And when it does that, it actually goes and it disrupts cell division, because cells, if you know anything about polar versus non-polar, namely some are very magnetically susceptible, and when a cancer cell tries to divide into two, it uses a scaffolding of building blocks to try to get that DNA material to separate. But if that scaffolding is disrupted by these low intensity, intermediate frequency electrical fields, well, then it can end up disrupting that process. And the angle at which that field is directed is important as well. So getting it from 2 angles in a sweeping fashion has been proven clinically effective. So here, this picture's a lot. I wish I could show you a little bit different one, but it's all of this. Let me kind of drill it down into the business end. So the stuff that is ancillary or auxiliary equipment for charging batteries, keeping it plugged in, and things like that when in a stationary way. Here's the battery charger. Here's the portable batteries that can then be loaded right here into the unit. Here's some portable battery case if you need an auxiliary. Here's the power supply that plugs in ultimately to the device. And this is one of the carrying cases. So where's the actual kind of thing that a person would be wearing every day? So it's this binocular-sized 3-pound device. It is attached to these transducer arrays through the connection cable, and then it's usually kept in a ventilated backpack. And I mean, that's the size of it. I'm not minimizing what it is. It's a commitment and a behavioral modification, no question about it. But honestly, it's not as kind of overwhelming as this slide may depict. That's just a very inclusive photo. So Tumor Treating Fields integrating in patient lifestyles. Obviously, this is where the rubber hits the road, because it's like a medicine. If a medicine is great, but if a person can't tolerate it, or if they're always vomiting from it or something like that, it doesn't do any good. So with respect to the Tumor Treating Field device, it's totally key from a social aspect, from a physical functioning aspect, but of course the stakes could not be higher. It's a clinically proved therapy, so really the oncology aspect usually is the risk-benefit ratio tipping the scales. And so it's portable, and you can see on the right-hand side, we have somebody wearing the backpack with his family, and the other patient ambassadors depicted. And so this is something that can integrate. And usually the steepest portion of it is kind of like, in a way, it's kind of like losing weight. I'm going to kind of crunch into, a little bit, maybe sometimes socially uncomfortable thing to talk about. So as a neurologist, way back in the day, decades ago, somebody would come in with low back pain. And so, you can do, non-invasive things, and stuff like this. But ultimately, if the person is, 370 pounds, the amount of torque that's on the back, or even 280 pounds, whatever it is, that's the first and best therapy. So how do you tell somebody, that they need to lose weight? Well, these, you could just pick up any magazine, and there's typically a lose 20 pounds quickly and a 5-layer, chocolate cake on the same cover. I mean, it's difficult to process many of those. But at the same time, what has to happen? There really, truly needs to be a behavioral modification. Even if there's an extreme intervention like a stomach stapling or, liposuction or something like this, honestly, in the end, it needs to be behavioral modification, that or smoking cessation or anything like that. So here, there is a learning curve. And so we're talking about integrating this device over a long period of time, because the way that the study was performed, that even after a first imaging progression, the recommendation and the protocol states stay on the device. This is, the tortoise and the hare. This is the tortoise. This isn't like a bolus of Avastin, for instance, where there may be very quick appearances of tumor control. This is one that takes a while, and that's why the earlier one starts it right after chemoradiation, the duration being the longest, the usage rates being longest. That's when we see the most optimal results that really tip the scales in the favor of the patient. So what about the actual lifestyle integration? Well, there are, as you see, patients can elect to wear hats, usually lightweight scarves, even wigs with, a mesh that's not too tight, being mindful not to get it wet or to get overheated per se. Skincare is really the name of the game here, because these leads have to be exchanged every couple, 3 days so that the skin can breathe, so that the head can be shaved clean instead of stubble, because then the device won't be adherent. We have to be mindful of skin integrity, because the leads are almost certainly going to be over an area that's been irradiated or operated or both. And so we want to be absolutely mindful of that. And we have some very effective algorithms for doing so. And sometimes we give people a little holiday and say, hey, listen, this is a long game, which is a great thing to talk about when you're talking about, control of a malignant tumor. You're like, hang on, don't lose hope, don't lose confidence. And so, there are other modifications which we went over, the sleeve bag, the 5-in-1 bag, and so on and so forth. And so, ultimately the key is going to be the social support that a person has, the infrastructure, the social infrastructure that can help a patient, that can accept a patient's new norm, so to speak, normalizing something that may be different. So for example, if a person, let's say in another disease state, like a woman's cancer who gets IV chemo, that woman will certainly go bald. And then the stigmatic part was bald is beautiful. I mean, some of those slogans that came up, which I loved. And in this case, it's not so much that, okay, a person goes bald, it's that it's pattern alopecia where the radiation went. It's self-induced, and then there's a device certainly in that capacity, and that self-awareness and self-perception is something that we try our very best to get a person to own. And I know that works best when they have a strong family support, and it really is. It's worth it in the sense that the numbers, the numbers don't lie. The imaging doesn't lie, and patients have had absolutely fantastic experiences overall. But of course, one would really be misgiven to say, okay, categorically, everybody's going to have the same experience, obviously. So one thing that I'll underscore here is the continuous exposure of this. So systemic treatment is here's one cycle, here's another cycle. And then radiation treatment, well, you give a fraction, you wait, you give another fraction, so on and so forth. Here, it's really a continuous exposure over time. You know, you may take, we recommend 75, well, not only recommend, that's what the clinical trial has demonstrated, 75% and greater usage rates, even in decile, every 10% that goes up, patients have improvement that's almost linearly related. And in fact, when patients have had 90% ability to stay on the device, the 5-year survivorships went up to 28%. So, I would challenge, and I wish somebody would answer that I'm wrong. I would challenge anybody to show a statistically significant study of this magnitude that has that kind of outcome. And so this is, again, as a neuro-oncologist, this is what I'm going for. Obviously, quality of life is at the core. Well, I want it all for my patients. I want quality and quantity hand in hand. And so when we have numbers like this that are statistically significant, that's not a fluke. So with that, hopefully, hopeful and encouraging ending, I'll pause and complete this presentation to take questions. And Delenn, I'll turn it to you for moderation.
Thank you so much, Dr. Nick. So I have a question related to Optune Geo, so TTFields. I think it's important if you could address that, when patients are using the Optune Geo device, Novocure provides people that are out and about that are there to help support and train how to put on the device. Is that correct?
Yes, it sure is. There's the device support specialists.
Can you talk more about their role and how they are helping patients wear this treatment option?
My pleasure. Thank you for that. The part and parcel of this is making it work at home. This is an ambulatory therapy. It's not something that you go in and get a dose. And so the device support specialist initially comes in and reinforces and takes sometimes hours to sit through and do almost a home safety evaluation per se, to say, okay, what's happening here? Where are you going to have this device to charge it? What's the safest way to do it? How do you prepare your skin? How do you, troubleshoot if you have any issues? How do we communicate the device usage data to your physician so that they know how things have been going and can best counsel you? How do we kind of make this as easy for you as possible, and how can we provide that? So these are folks, of course, at the patients and the caregivers scheduling will come out for regular or routine check-ins, for as needed check-ins to make sure that everything is going well with the device, and to make sure even things like hardware or leads or things like that are absolutely kept up to date. So those that's an integral part of our interface. And to conclude that remark, here is a device that has its own research development, production facility, medical component, and then home care piece. I mean, this is not a pharmaceutical company that manufactures its drug and then sends it. There's nothing wrong with that. I don't, belittle that in any way, shape, or form. This is the strength of this.
As part of the treatment plan for Optune Geo TTFields, sleeping in the device?
Yes. Yeah. And so I kind of think of that as, banking hours. If you're looking for a 75% aggregate exposure, I strongly endorse that patients will learn to sleep as comfortably as possible with them, because there you go. There's, let's say, 8 hours out of the day already. And so people sometimes they like to take a break every day. Other people will bank and just run, through a couple of days. And then when a special event comes, or getting out for dinner and letting the skin breathe, and, we're going to a special event, and if that's not the time to wear the device and go out to church, to, a wedding, or to a dinner, where, it's just, look, I'm taking a break. You can still bank well over 75% when being tactical about it. So those sleep hours really add up.
Very interesting, right? Hey, how much does the battery pack weigh in the backpack?
So the whole device, I think, about 3 pounds. I think most of the weight of that is in the battery. And then the backpack is, I don't want to mislead you, but it's probably half a pound or something. It's very light. And you bring up a very intriguing point, is that this is the only anti-cancer therapy that, like your iPhone, can be upgraded. You used to have a boom box, then it ended up being an iPod. Now, I've got a microchip, one half the size of my pinky nail. So more to come. No promises, but that's the direction. Yeah.
Okay, so I have one last question, and I'm looking, and I don't see any questions in the chat yet, but as you know, we, of course, work with and talk to patients every single day who are using the Optune Geo device. Does Novocure, I mean, I know you have, I forget what you call it, but it's your support group. People can email, they can call, but on as a regular basis, is Novocure addressing, the skin, I'm just going to call it an issue, right? We hear from patients, not every patient at all, that sometimes the arrays, can get hot, or they can cause a rash or itching, things like that, which is, we hear it a lot. I know you hear it a lot.
Mm-hmm.
Is Novocure considering, as part of their support when they're teaching and training people how to utilize this device, some kind of salve or something to also utilize for comfort?
Thank you, Delanne. Again, a very insightful question. I kind of think of it like a car wheel. I saw another commercial where it says, well, it's the only part of the car that touches the ground. So the arrays are the only part really effectively that touch the patient, obviously, when you carry it. And so, yes, it's a principal and primary focus of Novocure, and there's an algorithm, and there are algorithms for skincare that we not only counsel patients, but also nurse practitioners, nurses, physicians to go through that. And sometimes, we do have to have a dermatology assessment or something like that to really help with a high power steroid. But yes, staying ahead of it makes people enables patients to use the device more, which means statistically better results. So yes, it's a principal consideration.
Awesome. I'm glad to hear that. That's what that's what we're hearing a lot, right? So in the very beginning, we would hear, well, I don't want to wear it because what it looks like, and then we would talk about that. And then we talk about all the different ways you can wear the device with what you talked about, a scarf or a hat or even a wig, et cetera, and it took a while and years to address that, but it seems like that's addressed. And so what sort of seems to be coming up is what I just asked about, is it's that other part. And so I'm glad that Novocure is considering maybe how to incorporate that into part of their training.
Indeed. And, we have just in the past, let's say, year or so, have actually included in our global medical cross-functional team. Sorry for all of those terms, but one pillar to skincare from soup to nuts. So that's from the looking at the adhesive, to looking at the treatment, to working with dermatologists to improve it. I mean, everything, including literature that's educational and promoting understanding to healthcare providers, in addition, of course, to the patients, which is the principal focus. Absolutely.
That's fantastic. So it's very important for everyone to understand that the Optune Geo device is actually the very first device, as we talk about GBM, to be approved by the FDA. So in many ways, not only is Novocure providing another treatment option, which is FDA approved, which is part of standard of care, but they're leading the way for additional companies and biotech companies to come up with different devices to also be considered as treatment options, which is incredibly exciting. As we know, we need lots of treatment options for brain tumors and brain cancer and metastasized disease, by the way.
Indeed.
So thank you. Thanks, Nick, so much for joining us today. Really appreciate it.
Deland, it's always a pleasure, and I look forward to seeing you soon, maybe at ASCO.
You'll see Sean from my team at ASCO. I have a personal commitment this year that I cannot be there, but I'll definitely see you in November, if not before. If not before.
Thank you, guys.
So Nick's information is up on the screen. If you have any other questions about the Optune Geo device or TTFields and how they work, or how to access, or any other questions, feel free to get a hold of Nick. That would be great. Thanks so much.
Thank you again, and thank you to your audience. And
absolutely. And thank you to Novocure, by the way, for supporting our National Hope Award, that patient education, awareness, and outreach initiative that we started off today with. Thank you. It's really important to us.
Our pleasure. Okay, talk to you.